Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Karen Johnson from the AAFP about following the information blueprint, restoring joy in primary care. Let's get started.
Hello, Dr. Dan.
Hey, Faisel. Good to see you again.
Good to see you. Gosh, it was great being with you in California. And now here we are back again. Me over here in Florida and you in Virginia. And look who we've got with us today. Karen Johnson.
Hey, guys. The doctors.
How are you, Karen?
I'm great. I'm back from 2.5 weeks in California.
Been really busy. I know. You know, when we saw each other outside the that glass fishbowl podcast recording booth area, and you said something about we were talking about all the AI and everything that's going on, and you were talking about like how all this technology can help restore. I don't know if you said restore the humanity or just the person, or was that just me?
No. We're really very excited about the excitement that we hear from physicians like you all across the country who are really leaning into the opportunities that AI in particular represents. We're hearing, you guys, I think, probably are aware, we published a report in August that summarized the work that we'd done with Rock Health over the last 10 months, that surveyed physicians, that brought the tech industry together with family physician leaders and culminated in a summit that we held in May. And then the report is essentially here's what we learned, kind of 32-page summary. I can give you a much briefer version than that, which is that there's a reason to be optimistic. And I think that's the general sentiment that we hear. And I think the things that AI has been able to do early on, and think about ambient scribes and finding things in your EHR. Those are the things that we're hearing as like early wins and cause for great optimism. And those are the things that, and I've heard some people even talk about some of those things as, oh, that's just back office stuff. Well, maybe not. I think it's really actually not. I think it's much more about restoring the ability for physicians to spend their time and attention on patients and not the EHR and not the documentation and not the, all of those things that were getting in the way. So while there's great optimism, there's also reasons to be really alert and to pay attention and not let this happen to family physicians or primary care, but rather to really actively engage with the tech industry. And I think that coming out of this was sort of a really big lesson learned, is we've got to continue to push for ways to ensure that tech developers understand what really happens in care settings. So the solutions they're building are solving real problems and solving real problems in ways that can actually be implemented in real world settings. So there's a lot of work that we're thinking about and doing in that space as well.
In one of the articles, we've heard a lot of times people talking about top of license. And I think there was a phrase that you had that was top of purpose. What do you mean by top of purpose?
Well, that was a really important moment that came out of the summit conversation when, everybody's like, well, yeah, and the discussion was essentially about how AI can help to facilitate teams and team-based care. And one of the organizations there, we all know who they are, I think we can say names, CityBlock, Dr. Cameron Matthews was talking about how they are working to sort of take a care plan for a patient and translate that care plan into a workflow that sort of says, if you're this role, these are your responsibilities for this particular care plan, and so on and so forth down the way. So it takes some of that, it automates a lot of what used to be sort of, more maybe clumsy handoffs at time, or maybe less efficient handoffs, I should say, probably. And so a lot of people were talking about this is top of license. And we had one of our physicians stand up and say, can I just say that I don't really necessarily want to operate at the top of my license if that means I don't get to do some of the things I really value doing with patients. And so I do think, that top of purpose language became really meaningful to the folks in the room, and especially the physicians and other clinicians. I mean, let's all lean into the roles that we play. And I may be better at some of the soft skills than some of my partners. And just because I'm better at that, you get the picture. I mean, let's let everyone really do what they do well on the team and make it more about supporting that and allowing that to happen more organically. And I really think technology can support that as well. So it was a thank you for picking up on that, Dr. Dan. I think that was a really meaningful conversation and something that we've carried forward in our language. And it just, as a non-clinician, someone who's been supporting primary care for years and being a champion for it, it really resonated with me. And I guess when I hear it, I also put on my patient hat. I appreciate that from a physician.
Yeah, we heard a lot in California at FMX about bringing joy back to the center of medicine, and you don't really hear that from national organizations, like that joy should be a design goal. I think about when medical records were implemented and at a hospital level or even at like a community health level. I don't remember that ever being like a goal.
They didn't talk to you in med school about the joyfulness of the work that you were going to be doing through the rest of your career?
No. I mean, what does that mean to you? I mean, to design for joy in medicine and like using the AI and all the data fitting into all that.
Well, I can't hear those words and not think about Don Berwick and the IHI and all the work, which is really where a lot of that started. And I think, that was so many years ago. And the fact that we're working still so hard to make that happen. But as I've been out and I've been on the road for a few weeks and talking to, I went to the Civitas National Meeting, which is the health information exchanges and health data utilities and other regional and state data organizations. And then I was after FMX at NCQA, which was a lot of health plans, large systems as well, but quality organizations. And I think that along the way, every conversation comes back to what we are advocating for on behalf of family physicians is not what family physicians need. It's what we need as a nation, because this is a workforce issue. If we do not create the ability to have a meaningful, and not every day and everyone's job is joyful, but I can say I love my job, even though every day is not exactly joyful every moment, but I love my job. And we need people who are delivering primary care, whether they're physicians or other members of the team, because this is a top to bottom workforce issue in primary care. We've got to have good experiences for those folks, because if they don't have good experiences, their patients don't have good experiences, but more importantly, they don't stay around. And then who is there? So I do think that it just has to be part of the conversation that we are aspiring to make this a career that people want and desire and enjoy and stay in or choose. So we're trying to get people to stay because we've got people leaving too quickly. And we've also got to encourage more people to come.
I feel like with all this technology, like people even who left early, like especially, they think about like your typical kind of family doctor, loves people, loves relationships, and like, hey, all the tools that we're working with over here kind of pull us away from the things that we love. And now, like especially with the ambient AI, and there's so many other uses with the AI, I feel like that should be giving hope to a lot of doctors who left.
I hope so. I don't know how many will come back, but here's another really interesting, I think, perspective on this too, is our workforce is diminishing, but it's not always because you're losing a full FTE. Sometimes people are just reducing their clinical hours and choosing to do other things or make space for their life, maybe. But maybe we can bring some of those people back in a more significant way if they see an environment that is different than the one they left, and they see an opportunity to do what they really want to do, which is really focus on taking care of patients and doing that with a well-functioning team. And all of those things I think we're seeing are possible, but they're not easy in many environments. And the one thing I'm going to add here, and it has nothing to do with technology, but it has everything to do with how physicians and other clinicians do what they do today, and that is they're so frequently employed and larger organizations. And I think the other layer of this is those larger organizations that are making the decisions about what technology do I buy, what staff do we hire, and how do we schedule patients, and also even like how do we reward and incentivize what we see as good in those teams that are taking care of patients. All of those things really matter to what the experience of the workplace is. So while we can be really bullish and excited about the potential for AI in some of those ways, the whole world is much more complex than just the problems that can address. So there's some other layers of this that we spend a lot of our time at the AFP thinking about and working on.
What do you see AI doing to help? I like Faisel, agree that ambient AI is a game changer. When we got back from California, I realized now that the Doximity telephone call app gives you the ability to create an AI summary of a phone call now, which is huge. That was one of the things that I was wondering, why, when I'm talking to the patient on the phone, do I now have to sit down and type a summary when I have the ability to get a summary of an office visit real time? And now AI is taking care of that. But what I hear from providers is it's not the work in the room with the patient, it's how to deal with the lab follow-up, the prescription refills, all of the, the questions that are coming into the end basket. What do you see as hope on the horizon for that kind of work?
Yeah, that's a lot of what I was talking about pre and post FMX. We've been working a lot on that. And, there's a few layers of this. First of all, I'll say, so much of this is complex, just taking care of patients. But then you layer on value-based care or payment, and the things that come with that add another layer of complexity to what you're talking about, because it now is doing a level of population health and really proactive population health for a group of patients that are attributed to you as a physician or practice, and tracking performance measures and how are we doing against the expectations of the agreement. And so we've published recently what we're calling a primary care information blueprint. And it's really a guide or a framework to success in value-based care. And it really is focusing on just what you're talking about, Dr. Dan, which is the information and data flows. So what we did when we developed this was convene a group of smart folks, which is what we often do. And we have physicians delivering value-based care. We had population health companies who were really pulling the data together. We had EHRs, we had researchers who are doing a lot in that sort of data aggregation and data movement and interoperability fields. And we basically said, if we are going to support really high quality, value-based care, which again, one of the key distinctions of that is like its proactiveness. Like we're going to really reach out to this group of patients that we've accepted accountability for under this arrangement and make sure that they're getting all the things that they need, too frequently referred to as just closing gaps, which is not I don't think a very flattering way to talk about really making sure patients get all the care they need. But those are the terms that we use in the industry. So this blueprint, though, I think at the end of the day, the key things that we have as takeaways from that are that there's been a lot of improvement in the interoperability networks nationally. And we think that things are getting better, but there's still, need for improvement there. But the information that supports so much of this comes from payers. And payers and health plans are not a part of that national interoperability network. Say that 5 times. That really is, focused on clinical data, mostly the data that lives in the EHR. But so much of this is just, list of patients. And payers also, they know the whole care journey because they see everywhere a patient goes, their member, your patient. And so they have a rich amount of data that they have not been sharing in the ways that we think should be shared for mutual success for their members and your patients. So we're talking a lot about this sort of regional and state-based layer of data infrastructure, which we call, again, health information exchanges or health data utilities. A lot of variability exists in how those organizations function from state to state. But the meeting I went to before FMX, Civitas, is the national association of those entities. And there's some real star performers there. And we presented the blueprint with one of those entities, which is CRISP, based out of Maryland. And they do a really great job of mapping a lot of this data and making those things less burdensome in practice that you're talking about, Dr. Dan. But there's still a long way to go. But I think in terms of optimism, that community, HIEs across the country, is working together. They started 10 years ago an initiative called the Patient-Centered Data Home, which really helps them share. It's the network of networks and helps them share information with each other. And they really, many of them are also leaning into sort of the regional roles and that multi-stakeholder governance of the work that they do. And we're trying to encourage them to bring those payers to the table, bring your physicians leaders to the table and other clinical leaders in your communities and talk about these things. And the blueprint is really just a document and some research that we've done that really sets the table for giving them a more actionable way, focused way of working together on things that really will potentially make a difference in practice. I think still a whole lot more to come. I feel like we're getting traction in those communities and getting movement, but I think if there's a bright spot in terms of the problem that you identify, that's a bright spot I would point to, and one that we're going to continue to lean on pushing forward.
You bring up a good point. I remember Faisel and I both worked for ChenMed before now, and I remember when I first went to ChenMed coming out of academics. Of course, I'm back in academics now, but when I went there, I was talking to Chris Chen, the CEO, and he made the point, because I was talking about evidence-based medicine, and he said, well, Dan, money's evidence. And in fact, a lot of times the money shows markers much faster than somebody actually publishing a paper. And what we have is, we know that a patient who's on Medicare Advantage this year, likely next year will be on Medicare Advantage, but we actually don't know who is on which plan until like April of the following year. And so being able to get those data feeds so we can attribute it to our individual patients and not lose a third of every year waiting for patient lists to come out is pretty huge, because money is evidence. It doesn't mean it's all about money, but the amount you're spending on healthcare is a pretty good marker for how sick somebody is, right?
Right. Yeah. And the plans know these things. And the other thing we say, technology is not the problem. The ability to share the information is not the problem. I think it's, whether it's willingness or it's even just recognition that this is an important need. And so we're just trying to heighten the attention on the importance of this and in pointing to the HIEs, and also trying to help the HIEs understand their really potentially important role in this. Because imagine this too. Imagine, ChenMed or whatever practice it is. How many payers are you working with? Our data from members tells us that, more than half are working with 10 or more payers. So the majority are working with a lot. And I'll just say, and I've worked on the payer side, and I can say this with some degree of, firsthand experience. One payer can often look like two or three from a practice perspective, because there's a way of doing things for Medicaid patients, a way of doing things for Medicare patients, and a way of doing things for commercial patients or members from a health plan point of view. But if you're and they're always trying to come up with the solution that works for them. And their solution is, I've got a portal. And maybe it's even single sign-on across all three of my, market segments, but I'm still signing on to how many portals to pull information manually and then collate it. Imagine if you could get the dominant payers, if not all the payers in a market, to work through an HIE and to share attribution rosters so that HIE knows who gets the labs, who gets the admission discharge transfer alerts, who gets, the prescription information, and how quickly these entities can move that information is astounding. And the number of records that they're moving just with ease is astounding. So the mechanism and the technology and the infrastructure to do this is there. We're just not taking advantage of it. And so that's the opportunity we're really trying to bring attention to, so that imagine you could get a dashboard, a performance dashboard, or an attribution roster that is like, here are all your patients for all your plans in one place. Imagine.
Well, you can't have the good data flow though without without better payment models, and that's the thing that people outside of healthcare don't really understand. I was with my neighbor last night going over an abnormal chest x-ray. He was having some chest pain, ended up having an abnormal chest x-ray with a spot on his lung, and he was like, I don't understand why I can't get the doctor, my PCP, to go over this with me. And I said, well, like the system only pays the doctor for volume of visits. They're not paying the doctor to help manage this random thing, like the complexity. Like now you've become a complex, the situation's become complex. The system doesn't pay the doctor for that. And it's really hard for people who just want to go, and we're living in the time of finding instant, we're receiving things almost instantly. It's amazing. And people are finding access to information so quickly, but when the doctor-patient relationship, it shouldn't be this difficult for patients to be able to ask their doctor, the person that they trust. I mean, they could just as easily go to a chat GPT or whatever to find out whatever this x-ray report is. But he told me, he's like, I just really wanted to talk to my doctor. I couldn't get through to my doctor, so I called you.
It's interesting. There was a report that was published not too long ago about patients' perceptions of how primary care is paid. And their expectation was that, and I wish I had it in front of me and I wish I could quote it exactly, but it was somewhere in the range of patients thought that, how much of healthcare spending in the United States goes to primary care? Probably half was their estimation. And, we know the reality is like a tenth of that, like 5%, 4 to 5%. And so and we had the same conversation at all of the meetings I was just at when we were talking about information and data flows. Patients also expect that you have the information that you need to take care of me. Why don't you have my labs? Why don't you have, I've signed all the papers that give you the ability to get those. So why don't you have those? So there are some definite mismatches there between what patients expect and what's actually happening at a system level.
Yeah, because, we don't need any favors with people not trusting. I mean, we got enough challenges with just trying to maintain trust that, hey, we're there, like family medicine runs on trust. And especially when you're dealing with the too good to be true or too difficult to get done populations of people.
Yeah, for sure. And, we just continue to see that in the data for sure, that people, when it comes to trust, on health information, it's definitely their physicians and their other providers.
How can we build the trust back, though? I mean, not just between the doctors and the patients, but also I see that with doctors and like the primary care and specialists, and even the doctors and the teams.
Wow. How much more time do we have for that one?
I mean, we were, it was great. We were at FMX and we were seeing all these amazing technologies. Dr. Dan and I were walking through, and it was just incredible. There was this one company that had a handheld portable ultrasound, and on your device, it outlined all the anatomy real time. Like you could pause it and it lets you, you can use it as a tool to educate your patients.
And labeled it.
And labeled it.
Yeah, it was just like the radiologist with the red grease pencil, right? That was circling something for you to look at, except it was done, I guess, with AI to give you that.
Yeah, I was just thinking in that moment that, gosh, in the clinic, having something like that, and then me being that trusted person for the patient, and then having this tool, and then using this tool that they can see their body real time and they can understand their body better. Like I just viewed it as a tool to help me, help have a conversation, help restore trust, help restore faith, whatever you want to call that. But I just feel like so much, like we've gone so far away. And I don't know if it's safe to say it's because of the models, the payment models kind of made everybody, everything has become so transactional. Like, with the doctor and the specialist, the patient and the doctor, like now we're using the same technology to kind of bring everything back.
Yeah, for sure. But, I do think, taking it back to sort of the AI conversation and the technology and the tools, I think patients want that sort of level of sophistication in their care. They're looking for that. So there's going to be an expectation for that. But I think it's pretty clear also they don't want that in lieu of, as you're saying, they don't want that in lieu of the Dr. Faisel or Dr. Dan with them in the office telling them, yeah, this is what this means. And this is what you should be concerned about and what you can do about it. This is what you don't need to worry about. Just that kind of conversation. And I think, back to sort of the summit and all that we learned through the last year working with so many smart folks on this, AI as a tool and almost like treat it and think of it almost like a member of the team that you can use, but it is not a replacement for anyone on the team. And I think it can help build trust across the team. I think it can help to build trust potentially with patients if we get implementation of it right. But we will see on that front. I mean, there's still a lot, like I said, lots to be optimistic about, but lots to have our eyes wide open about, and I just think, and we've been talking about data. Data is one of those things. AI is only as good as the data it is trained on. And so we need to make sure we are aggregating data that really represents the patients that you are caring for, because if it's really, when you get into that clinical realm, so many opportunities for this to go a different direction without some really careful oversight and governance. And that's where I think this whole initiative from the AAFP to really continue to build bridges between those delivering care and those developing the technology solutions. How do we make sure that clinical voice and presence is there throughout the innovation life cycle? Because the clinical context at the end of the day is sort of really what matters when it comes to getting outside of ambient listening and some of the documentation things we're talking about here. So really seeing physicians in leadership roles and just creating opportunities for practicing docs to, test and talk with technology innovators feels like a really, really important mission critical part of this journey that we're on. And I hate to say it, go back to the, EHRs, let's not let it happen to us. Let's make sure it's happening with us.
Especially with the independent practices. Like the small rural clinics. I mean, they're so busy. You work for a big system, there's going to be like a chief technology officer or something, but like for these small practices, these onesie twosie doctor practices, and oftentimes they're underserved. I mean, you're in a rural area. I mean, you're an underserved practice. Like a lot of them, I worry about them not being left behind with all this.
I think totally. The big concern that came out of our conversations, let's not make this a universe of haves and have-nots when it comes to the technology that's available. Let's make sure we can make it accessible in some sort of meaningful way. But the other thing that's kind of empowering from an independent practice perspective is you get to make the decisions. And like I said, so many physicians are employed in situations where maybe they can be influencers, maybe they can be champions, and we're certainly trying to equip them with the knowledge and information to do that. But they're not making purchasing decisions. And so those and I'm even aware of some folks who are leaving systems to go back to independent practice. That pendulum, could it have swung as far as it's going to swing? And could we see some movement and correction back? I don't know. I mean, this is very anecdotal, but as we talk to other associations on the practice side and elsewhere, we're not the only ones reading the tea leaves this way. So we're really doubling down on our efforts to support independent practice in a lot of different ways, both from how do you make sure you're leveraging all of the payment opportunities that exist, whether that's just understanding all the fee-for-service opportunities and or value-based payment opportunities. It's also the technology and how you team your practice.
Gosh, I would love for that. I mean, I feel like it's happening already, especially with the direct primary care movement, how so many residents are now opening up their own direct primary care practices and now some of the rules changing for 2026 where you can have both. You can take commercial insurance and also have your own little direct primary care practice. If we had to, I know there's a lot of talk about, going back to when things were great or whatever, but if we could go back with 2025, go back to 1985, where your typical doctor, primary care doctor could just finish residency, put up your name up on a sign and just get to helping people. That would be, I could stand behind going back to something like that.
Yeah, for us, as we're working on this and thinking about this, independent practice really means physician ownership and leadership at the practice level. And that can exist in so many forms. And that's one of the things we're trying to elevate, which is, maybe it is exclusively direct primary care where you're just contracting directly with patients. And we also know of opportunities or situations where folks are like, but it could be direct primary care and Medicaid. Met a young physician at a meeting who was really passionate. It's like, I worry about the people who can't pay, so I take Medicaid and others will pay. I know some who work on a sliding scale, but also the things that have changed in the legislation and open things up for employers in a different way to do direct contracting and make that more attractive. So it's pick your flavor. It might be all I do is insurance, all I do is direct primary care, or some of many combinations that exist in between. And so really think that there are so many ways to build this that we're trying to open people's eyes up to all of the possibilities.
We've got somebody I think is going to be a future guest on the podcast who was working in a leadership position for a health system. And they said, well, we're going to have to cut back on the funding, the support we're giving you for the leadership position. We need you to see more patients. And he wanted to do sort of what Faisel was talking about, continue his practice with that group, but also start his own direct primary care on the side and just take the cut and pay. And they said, no, we're not going to let you do that. That'd be a conflict of interest. So we're not going to let you do that. And so he walked and he's starting his own direct primary care practice. So it's interesting. I would say 10 years ago, that was very difficult to do. Now it's getting much easier, and primary care is clear that it's so valuable, but nobody's going to value us if we don't value ourselves. So that's figuring out how to get your place at the table and feel comfortable speaking up when things are being brought to the table to talk about it.
Yeah. Amen to that.
Yeah, we have to share the data. That's the thing. What Karen was mentioning earlier. It's unbelievable that in 2025 all that information is not readily available. And we see that so I work with Dr. Matthews at City Block, and that was one of the big surprises I saw. Coming in to City Block is just seeing like a lot of times the data systems, you don't see the suffering of the people who aren't showing up in the data. They're the ones who are struggling the most, right? They're the ones that aren't engaging properly with the healthcare delivery system. So I feel like having like this type of, shared data, shared, success, right? That could actually make health equity more measurable.
Yeah, I would just say if there's anyone out there listening who is a physician or running a practice or in that ecosystem that wants better data, go knock on the door of your regional or state-based HIE and talk to them. Find out what's possible, encourage them to start talking with the payers in their regions, and, really just roll up your sleeves. Sometimes it's as simple as that. If you're not asking, it's not happening.
Yeah. Dr. Dan, when you first finished residency, I'm sure there were doctors who were just the productivity doctors, right? Like the volume doctors, but that wasn't, when I think about medicine in America and how so many doctors from around the world want to come practice medicine here, they're not thinking, they never thought about productivity. I'm sure there were doctors who were productive, but it's like when the doctors gave the control to the business people, then suddenly it was all about productivity.
Right. I think it's you do need to keep your hand in, because money helps drive everything. So you need to understand how the money flows in a practice. I mean, practices can't function without providers, but you need to make sure that you're in a position to provide input to that. We used to, back when I was a resident, was before all the provider-based clinics. And so even at a large academic medical center, the clinic was being operated by the faculty. And so every month there was a business meeting. And when you were a senior resident, you had to be part of that business meeting and you had to help do the reports. And there was a P&L statement. We saw this many patients. We were averaged this much collections. This is what we are doing as far as accounts receivable. And you got a pretty good baseline of that. And whether you're running one doctor practice or you're running a huge office, a huge health system, you've got to be able to look at those numbers like that. And so I would encourage anybody going into healthcare, you're entering a big business, so learn about business along the way, either formally or informally, because that's going to be important for the work you're doing.
Yeah, and we haven't spent a lot of time talking about payment per se today, but I do think, the incentives of the system still point toward volume and high intensity services is sort of how the nice words I use to describe it. And it fundamentally really, having sick people in your population, if you're a hospital system, is what drives revenue. I mean, that's just the bottom line to the way the system is structured today. I've talked a few times today about bright spots. I will say the fee schedule proposed rule for 2026 did have a couple of bright spots. They're small movements, but they're directionally right. But they proposed some deep, weedy technological or methodological changes in payment around that would really shift in favor of primary care, whether that is around cognitive versus procedural care, and then also facility versus non-facility care. So, I just think, again, just directionally, along with some other things that they've been doing around advanced primary care management services and opportunities there, still some work to do there, but there's definitely some movement in the right direction. But the fundamentals are what the CFOs are responding to. It's where the incentives point them as a business.
And I feel like burnout, definitely there's been a huge shift with burnout this year with doctors at the national meeting over the summer and even just now with FMX. There is a feeling of joy, right? I'm feeling that. I feel like finally doctors are feeling happy again about taking care of people. I meet with my team regularly and we go over metrics around trust and, the NPS scores and things like that. And it never came to me, even as a doctor leader in a value-based care model, do we have a sense of how our teams are doing with their joy? With all the burnout that we have in primary care, I love how the AAFP says that joy should be a metric, especially when we were in such a scary place last year. Think of where we were last year compared to now.
Yeah, for sure. And I just, I almost got chills when you were talking about sort of this moment, because we just had our post FMX celebration here back in Leawood, Kansas, and we had over 4,500 physicians and almost 10,000 people there supporting family medicine at this conference. Was just a particularly a moment where it feels like we are maybe really kind of shifting again, like I said, in the right direction and coming out of what has been maybe a tough few years, coming out of COVID and some of the things that really were hurtful at that point in time. I think we've moved beyond, but there's still a whole lot out there to be concerned about. But it's just nice to have things to be so optimistic about also.
Well, Karen, I really just want to thank you for taking the time to join us. This is not just policy work you've been doing. This is legacy work. I feel like we got into the 21st century, excited about the 21st century, but everyone else went so far ahead, like the finance and all that. They're dealing with financial information that so effortlessly and so efficiently with the phone. But now I feel like this work that you've been sharing with us, I mean, this is going to help redefine what it means to be a helper, a healer in the 21st century.
Yeah, for me, this is heart work. This is, I do it because it needs to be done. And we all at the AFP, I think that is one thing we all share in common, is a real commitment to the mission. And that is fueled by the hearts and passions of our members, the family physicians, and all of your teams. I mean, that's just really what it's about. So we want for ourselves what you want for your patients, and we're all in this together.
Thank you so much. Dr. Dan, like less clicking for doctors, more connecting.
Yeah,
that's right.
That's the revolution we're going for, right?
Yep. I like that.
Thank you.
Thank you guys so much. Really appreciate it. Great to see both of you.
What are your thoughts on following the information blueprint, restoring joy in primary care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.